You wake up one morning and the person you love most in the world, your mom, your husband, your best friend, they can't get out of bed without you. And not because they're tired, not because they're having a bad day, because their body has been slowly, systematically been shutting down. And nobody, not the neurologist, not the discharge nurse, not the pamphlet they handed you at diagnosis, nobody actually told you what that looks like, or what it feels like, or what the hell you're supposed to do about it. Today I'm going to tell you everything that brochure left out about what it really means to care for someone in the progressive stages of this disease. So let's clarify some things, because progressive MS is one of those terms that gets thrown around a lot without much explanation. There are two main types of progressive MS. Primary progressive, where someone never really had relapses, their function just slowly declines from the start. And secondary progressive, where someone started with relapsing remitting MS and over time transitioned into steady decline. Now, keep in mind that 85% of all MS cases are relapsing remitting MS. So the progressive part really isn't that common. What they share is the nervous system is ultimately losing the battle. Myelin, of course, the protective coating around the nerve fibers, has been damaged. And when myelin can't protect those signals anymore, the messages your brain sends to your body start, getting lost. That means, depending on how far the disease has progressed with you or your person, you might be dealing with significant mobility issues, like needing to use a cane, a walker, a wheelchair, or maybe even being bedbound. Spasticity, and that's when the muscles that are constantly, they're tightening, they're cramping, or seizing. Bowel and bladder dysfunction, and I want to say this plainly because a lot of caregivers and, the patients themselves are blindsided by it. Cognitive changes, memory, word finding, kind of a processing speed, and severe fatigue, not tiredness. This is neurological fatigue. It's a completely different beast. Then there's pain, and that's neuropathic pain that doesn't respond to typical over-the-counter medications, as well as dysphagia, and that is difficulty swallowing in advanced cases. So in the progressive state of MS, this is not the same disease that it was at diagnosis, and the care required is ultimately not the same either. Okay, going nursey on y'all. So I'm going to talk about what caregiving for someone with progressive MS actually involves physically, because I think a lot of people don't fully grasp this until they're in the middle of it. First, you have mobility and transfers. So if your person has significant weakness or paralysis, you may be needing to do assisted transfers, and that would be helping them get from the bed to the wheelchair, maybe from the wheelchair to the toilet, or maybe from the toilet back to the bed. And this would be multiple times a day. This is physically demanding. It's the number one reason caregivers develop back injuries. And if this is you, please learn proper body mechanics. Ask for a referral to a physical therapist for caregiver training, and look into assistive equipment such as a gait belt or a Hoyer lift. And you have to know this is not giving up at all. This is protecting both of you. Skin integrity. So when someone can't reposition themselves, pressure ulcers become a real threat. And on the nurse standpoint, this is something that is ultimately hammered into us. With this, you're looking at bony prominences. So this is like your heels, your tailbone, your hips, even maybe your elbows, the back of your head. There's a few more, but repositioning every 2 hours and proper mattress support and keeping the skin clean and dry. This is all involved in preventing this kind of thing. You should more than likely have a nurse in home care help you train to understand these things, to help you know what to look out for. And of course, if you see anything, immediately you'll want to contact that nurse. Bladder care. Many people with progressive MS may use a catheter, and that can be either an intermittent catheterization, which means there's nothing that really stays with them. They do it as they need to, or an indwelling Foley. If you're managing this at home, you need proper training, again, likely by a nurse. Ultimately, it should be a nurse that manages this, but you'll be learning about what to look out for. Something like UTIs, for example, in MS patients, it can cause pseudo-exacerbations. And that's a sudden, severe worsening of symptoms that look terrifying, but is actually reversible once the infection clears. Signs of a UTI in someone with MS can be subtle, something like maybe increased spasticity, confusion, and just not acting like themselves. Medication management. So progressive MS often involves a complex medication regimen. So things like antispasmodics like baclofen, bladder medications, pain management, possibly even, likely a disease-modifying therapy. It'll be very helpful for you to know what everything is for and to understand that. So you'll want to keep a current medication list, or likely even chart to document like the times and keep track of each medication, and then bring that to your doctor's appointments. And please ask the doctor about fatigue management. There are medications that can help, and pacing strategies and occupational therapy supports. Don't just accept that your person has to be exhausted all day, every day. All right, we have to talk about the part nobody wants to talk about, the grief. It might be the worst part of MS, honestly. I mean, it kind of was for me. Because caregiving for someone with progressive MS involves grief. Not the grief of death, but anticipatory grief. Both you and the patient are grieving capabilities as they change. You're grieving the relationship you had before. You're grieving your own life, your plans, and your freedom. And as the caregiver, you're grieving while the person is still right there in front of you, which can feel disorienting and even shameful. And I want to say very directly, those feelings are not a betrayal. They're human. We're all human. And the person with MS, they're grieving too. Every loss of function is a loss of identity. Every time they need to ask for help with something that they used to do independently, that's a moment of grief. And that grief can sometimes come out sideways, as frustration, as anger, as withdrawal. And here are a few things that can kind of help. For one, keep communicating. Even when it's hard, silence breeds resentment. And you might be saying a lot of not so choice things to each other. In that case, you're going to have to accept that and put your hazmat suits on. Both of you need to learn to name what's happening. You got to say something like, "This is really hard, and I love you, and I'm not going anywhere." Just say it over and over. This one's huge. Don't disappear into the caregiver role. You are still a person and you have needs. The research on caregiver burnout is stark. Isolation, depression, physical illness. And I say this with a pretty significant amount of expertise as a burned out nurse. You cannot pour from an empty cup. And I know that sounds like a coffee mug slogan, but it is clinically true. Respite care isn't a luxury, it's an absolute necessity. Next, seek peer support. The MS Society has caregiver support groups. Online communities exist. You need to find the people who get it, who don't need you to explain why you're exhausted when the person you're caring for didn't even go outside today. And if you are the one with MS, watching someone you love sacrifice for you carries its own weight. Communicate what you need. Let people in. You do not have to minimize your needs to protect the people around you. There's no prize for caregiving alone, and there's no prize for constantly sucking it up either. All right, let's talk strategy, because the healthcare system isn't really designed for complex chronic illnesses, and you're going to have to be your person's advocate. You need to build or find a care team and know who does what. Neurologist physicians are specialists and they manage the disease itself. Primary care doctors, they manage everything else, and that everything else matters enormously. Then you have a physical therapist for mobility and strength, occupational therapist for adaptive equipment and daily living strategies. Then you also have speech therapists if there's any swallowing or cognitive concerns. You also might encounter a urologist who's another specialist if bladder issues are complex. Ideally, you want a palliative care team, and this is not because your person is dying. I think that gets confused a lot, but because palliative is actually, it's care that specializes in the quality of life and symptom management. Many people don't realize or know that. The big one, and I've said this a couple times, document everything. Keep a symptom journal. Track what's changing, when, how fast. Bring that to your appointments. Neurologists see your person for, 20 to 30 minutes every few months, and you're seeing them every day. Your observations are actual data. You also need to understand within symptoms and these sudden changes of the serious ones versus the not so serious ones. Things like maybe sudden new weaknesses, vision changes, severe pain, fever with a catheter in place, difficulty breathing or swallowing. Some things of those, particularly the breathing and the swallowing, those warrant urgent attention, and the fever too. But a pseudo-exacerbation from infection resolves with treatment. A true relapse may require IV steroids, so don't wait and see when something feels wrong. This one is a big one for me because, it's kind of really what I do. Ask about home health and community resources. You've got home health aides, visiting nurses, home PT/OT, meal delivery programs, transportation assistance. These things all exist. Many families don't access them because, they don't know how to ask. You or your person's neurologist's office or a social worker can help you identify what's available in your area. However, the best resource will always be your insurance. You'll not only know what's available, but what's covered. I want to close with something that may feel premature or uncomfortable, but I promise you it is an act of love. Have the planning conversations now while your person or you can fully participate. And let me just back this up with MS is rarely fatal. There's advanced directives, a healthcare proxy, financial and legal planning. What does your person want or you want if you can no longer speak for yourself? What are your values around aggressive intervention? What does quality of life mean to you or them? These conversations are not giving up. Again, no one's going to die tomorrow or even in months from now. This is just honoring you or the person you're caring for. And families who have had them, even though they're painful, consistently report they feel more at peace when difficult decisions have to be made because they know that they're honoring what that person wanted. If you don't know where to start, ask the neurologist for a referral to social work, case management, or for palliative care. They do this sort of thing every day, and chances are they'll be good at it. If you're in this, if you're caring for someone with progressive MS, or you are the person with progressive MS, or you're watching this at midnight because you're scared shitless and you don't know what comes next, I see you. This is one of the hardest things a person can do. It requires more than most people ever expect to be asked to give, and you're doing it anyway. The most important thing I can tell you from both sides of this, as a nurse and as someone living with this disease, is that you don't have to be perfect at this. All you have to do is keep showing up, keep asking questions, there are no dumb questions in this case, and keep asking for help. And I'm going to reiterate this again. There is no award for doing this alone and for acting tough. If you found this helpful, please share it with someone who needs it, because I guarantee there are caregivers out there right now who have no idea that these resources and strategies exist. Also, check out my link, of course, in the description for emails containing freebies and my work in progress website. And as I'll always mention, drop a comment, of course, especially if you have any major concerns in the caregiver department. Like and subscribe if you want more of this. I'll even take more comments of what you want content-wise. I'm open for that. I'm here to give you real information from both sides, patient and nurse, from someone who, actually lives and sees it. With that, thank you oh so much for watching. You guys have meant so much to me, and I will definitely see you in the next video.